Hammill. It got actually started in journalism and sociology before going into biostatistics, receiving his Dr. PH at Chapel Hill in North Carolina, and now is an associate professor in population health science at oops, at Duke. Sorry, brief moment of brain freeze. And he is interested in taking real world data like health clearance data, electronic health record data, which contain a wealth of information and leverage them for clinical research. And I'm very excited because I've had an opportunity to work with him on some of this on our Reliance trial here at the Center for Clinical Trials at Hopkins. And so I'm very interested to hear about some of his other work today. So I'll turn it over to you, Brad.
All right, thanks so much, Elizabeth. Happy to be here. Um, if you have questions, you can throw those in the chat and they'll interrupt me. And that's fine because I've been working in this space long enough where I assume some things and might say some things that if it needs some clarification or if you want to know what more about it, just let me know and we'll do that. So yeah, as Elizabeth said, I'm talking about leveraging real world data in clinical trials. Kind of real world data in trials is something that defines kind of one very particular branch on the pragmatic clinical trial tree, so to speak. And so it's something that we've been working on a while and happy to share with you all. So just a few disclosures. FDA has been involved in a number of funding a couple of the studies that I'll talk about today. PCORI, NIA, and GSK all have funded various things that I'll talk about, and no relevant conflicts. So the general outline is to kind of just give a real brief overview of real world data, especially again, as it kind of relates to how it might be useful as a follow-up for clinical trials. Or for other aspects of clinical trials. So then I'll talk a little bit in detail about the Harmony Outcomes Ancillary Study that was one of the first things we did in this space. And then I'll talk about the Corey's adaptable trial, and then give a little bit of detail on the preventable trial, which is actually still happening right now. And the goal is to kind of, at some point, synthesize some of the challenges and opportunities for real world data in trials that we've kind of experienced over time and that I think we're still experiencing. This is an area that's really, we're still learning a lot about how to do. And I think the technology of electronic health record and claims data access is really still evolving. So it's funny, I kind of want to start at the end, but the end here is the FDA guidance, right? Because at least the Harmony work that I'm going to talk about was it was cited in this work, right? And I think, if I'm not mistaken, that even the Reliance trial was funded in the hope that it might contribute knowledge to this guidance, but that trial was slow to launch. Like, right? Am I remembering this correctly, Elizabeth?
We actually added it late, but well, no, actually, you're right. In the original, we did want to use the data silos. That's correct.
Yeah. So it's funny, like even Reliance is related to this guidance in some way, but um, this guidance was a long time coming, right? Assessing electronic health record data and claims data to support regulatory decision making for drug and biological products at the FDA. Um, the reason this guidance exists is because in 2016, the 21st Century Cures Act directed the FDA to establish a framework for doing this. Um, and so there were a couple drafts of these things over the years, and then in September 2021, they finally released their draft guidance here. So what is it? What kind of real world data, are we talking about? Um, they specifically call out electronic health record data and claims data. For those, this probably shows my age because this was a 2014 graphic from a manuscript that I consider like to be a classic in the real world data space. It really helps us to think about the full range of health data that's available and where that data might or might not be found. Um, so yeah, you can see here, for example, that like they consider claims data to be this little purple box, and they consider kind of electronic health record data to be kind of this big blue box. But there's more data out there, of course. It's just that that's the stuff you can kind of get, and they separate things between structured data and unstructured data. So it's a nice, if for nothing else, to think about the real world data. So as defined by FDA, real world data are the data relating to patient health status and or the delivery of healthcare routinely collected from a variety of sources. So um, electronic health record data is really specific to a health system or a standalone clinic. It's collected and optimized for patient care, and it's a picture of healthcare delivered in that system or clinic. Um, but that's really the scope. Claims data is specific to a payer, right? Collected and optimized for provider payment. What's great about it, though, is that it's a comprehensive picture of healthcare delivered for people covered by a certain insurer. So those are the two kind of data sources that we're going to talk about today. One of the other things that kind of I've worked with at Duke quite a bit is registry data. Registry data is real world data, and there are trials that leverage registries and things, but that doesn't have the bulk of data that kind of we're talking about today here. So it's kind of true that the FDA has been using claims data to support regulatory decision making for years via the Sentinel database. So I don't know how many people are familiar with the Sentinel database, but it's a distributed database where the data partners are almost always insurers. So like there's the private ones, Blue Cross Blue Shield, uh, Cigna, I know Kaiser's involved. My team at Duke manages 100% of the Medicare data and 100% of the Medicaid data for the Sentinel claims database. So we do that in the CMS virtual environment in the VRDC. So what's interesting about this database is that it's distributed, meaning that the data partners each manage and control their data, right? The operations center can query that data, but the operations center doesn't hold the database or have essentially direct access to it in any way. So um, in order to work with data in this type of setting, they had to, of course, define a common data model. So that means every data partner transforms their claims data into this data model for format, this data model format for querying. So we all have the same tables with the same names and all the same variables with the same values. Um, and that enables the operations center to send a single program out to all the data partners, um, get the results back, and then they kind of aggregate the results at the operations center before sending it back to the FDA. So they also, one of those queries that they send to all the data partners right after each transformation is a data quality thing. So they assess the data quality of everybody's database to make sure that kind of everything matches what they expect it to be. So it's it actually has turned out for, I mean, over 10 years to be um, a very robust system. There's been a lot of great information, I think, generated by the Sentinel database over time. But so claims data, kind of, we've seen it work here. Um, I assume most people know the basics about claims data, but I'll just kind of jump into it here. It covers nearly 100% of the U.S. population over age 65. Um, Relevant to trials, we really want to have recent data for folks, especially if we're following people prospectively over time. So in that regard, only some Medicare beneficiaries have comprehensive recent data available. So those are the folks in the fee-for-service program. Fee-for-service data are available currently through Q4 2024. Um, for those involved in or enrolled in Medicare managed care, there's a much longer latency. It's kind of harder to use for prospective follow-up. You can, especially if your trial goes on for a very long time. Um, but currently, I think the latest managed care data that's available is through 2022. Um, so that's the medical side of things. If you're interested in kind of drug-related questions, 80 to 90% of people in Medicare are enrolled in Part D, and that data is also kind of it's lagged like the managed care data, so it's really only available through 2022. But it's a great data source. It's comprehensive. We've used it. I mean, a lot of people, right, have used it for healthcare research of all kinds. So it makes sense to try and use it for trials. Um, The availability of EHR data, though, is a relatively recent thing, kind of electronically. I mean, recent, again, I'm an old guy, right? And I started doing this when EHR data really wasn't that available. So when this whole meaningful use and um, uh, there were all these incentives to get people to actually put their health records into electronic format. This was the kind of ramp up we saw from under 25% all the way up to, basically high 90s%. So the idea is that it 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 made sense, right? With all that data, we should be able to tap into it and use it um, for uh, for research. And I will say, I think I forgot to mention something on an earlier slide. So I worked at the Duke Clinical Research Institute since the late 90s. And the head of the DCRI for a long, long time was Rob Califf. So Rob Califf, of course, has now been the FDA commissioner a few times. But this idea that real world data should be able to give us more information for health research and for regulatory decision making has been on his radar like forever. And so his fingers are in a couple of the first trials that I'll talk about, and I think he was maybe one of the big people to push that guide, the need for that guidance on real world evidence, back 10 years ago. So it's funny that the connections that we have there. So there wasn't a database um, like the Sentinel database for EHR data. And so again, this was probably less than 10 years ago, but kind of around there. PCORI established PCORNet, which is the National Patient-Centered Clinical Research Network. They really wanted to apply these Sentinel principles to EHR data. So they again wanted a distributed database where every kind of health system, and at least initially it was a lot of academic health systems, um, again would hold their own data, and then we would query it through a coordinating center. So they also set up a common data model. Because it was using slightly different data, they had a slightly different common data model from Sentinel. But again, the idea was that data partners would transform their data and that the coordinating center would send a single query to all the data partners, and then the results would be aggregated. So that still exists. Duke is still a coordinating center for PCORNet. You can see what that common data model looked like kind of way back. It's expanded for now. I think for anybody involved in common data models, one of the favorite sports is to keep expanding it and to keep getting more and more information into it. But this was the core, right? It was structured information about demographics and encounters, diagnoses, procedures, vital results, labs, that kind of thing, right? So these really, and the more structured data that you have, that's easier to get into a common data model. I know there have been recent moves to make unstructured information available into the common data model, but that's a little more difficult. Um, but anyway, just to give you a sense about kind of what we're dealing with here. So we'd seen these distributed data models work, and we thought, you know what, we're gonna do that in a trial. We're gonna talk to some trial sites, and we're gonna get them to put their electronic health record data into a common data model, and we're going to query it during a trial. It's going to be amazing, right? So we partnered with GSK. They had a trial ongoing for abiglutide, which was at the time, just a blood glucose lowering therapy. They were doing kind of a late phase trial on major cardiovascular events in patients with type 2 diabetes. They had, 9,000 subjects, it was 28 countries, 644 sites. Um, and we had really grand plans. The guiding principle, of course, now was that the EHR is a rich source of clinical data. It's being used in pragmatic health research initiatives, but we don't know if it can work for trials. So let's see if we can work it for trials here. So we really wanted to understand how it could help. So we wanted to, try and work with sites to organize their data and query that data in a cost-effective way. Um, because ideally, you know, if you can leverage all this data that exists in the world, you might be able to transform trial conduct in some way, right? And reduce personnel burden of having to, do the two-screen thing where they've got the EHR on one screen and the trial CRF on another, and they're just kind of moving data back and forth between them, like as a person. seems a little silly, right? Um, okay. Some of the things I'm going to describe to you, of course, on this trial are things we're still dealing with today, like in terms of difficulties, but this is what we planned. We really did plan on sites creating their own data mart, kind of with a whole chunk of their EHR data so that we could query it just like it was PCORNet or Sentinel. And we were going to talk about, understand what the data looked like and how it was that people worked from, kind of the big population down to actual trial recruitment. We were going to take a look and compare how EHR data for baseline characteristics compared to the trial ECRF. And then same thing for outcomes. How would outcomes compare? And how would you do that during the trial? Again, to assess the necessity of parallel data collection, can we reduce any of that? Well, pretty early on, GSK, I think, finally realized if they find things in the EHR data that we don't know about, then we have to somehow incorporate that into the study. And they did not want to do that. So one of the first things that changed was they're like, okay, you've got to wait until the database locks before we're going to do this work here. So we had to kind of reorient our objectives. And since we have more time, we actually expanded the study to incorporate kind of claims data. So it's still called the EHR ancillary study, but we were like, well, let's evaluate the fitness of real world data for populating baseline and for identifying clinical endpoints. The whole recruitment barriers thing was just ended up being a site survey. So we had the chance now to figure out these two objectives using actual data, but we realized we couldn't easily ask like Denmark, who contributed sites, or Sweden or the UK to like make a data mart that we would query. So we actually kind of split things off into two different strategies that I'll talk about. Um, the top strategy here was the national strategy, where we would work with a national partner because so many nations apart from ours have a national database of some sort related to kind of health information, right? So we were going to work with Sweden, we were going to work with Denmark and the UK, and we would just get a national partner over there. They would do whatever it is that they do and give us the results that we were after here. I'm not going to talk about that today because that was a whole separate thing. It was happening right around the time that GDPR was happening, which is the General Data Protection Regulation that prohibited data like this from transferring across borders. So that became a very difficult strategy where we got limited to, I don't even know if we ended up getting much information by that strategy. So I'm not really going to talk about that. I will say, though, that the US Medicare data was considered a national partner and a national strategy. So you'll see claims data results, and it technically came through that strategy, just so you know. But what we did in the US was, again, this whole idea of data mart strategy. Let's try and get these sites to put their data into a data mart so that we could query it. So that was kind of in the US only. So for the national strategy Medicare population, we contracted with 9 sites that had 132 participants. We were able to link 70 of them to Medicare, which means we could use 70 of them for demographics information. But only 38 of those were involved in in parts A and B, which enabled us to get medical history. Only 53 of them were enrolled in part D, meaning we could get information on medications for 53 of those. Just keep those small numbers in mind when we talk about what we're dealing with here. The challenge in this trial, of course, was that not everyone in this trial was 65 years or older, right? And even if they were, they weren't all enrolled in fee-for-service Medicare. Another challenge was that we had to reconsent patients into this ancillary study individually, which was difficult. Ideally, you would do this at the very start of a trial and just have, be able to work from a single consent, but that just wasn't the case here. So for the data mart strategy, the goal was to hopefully get like 12 sites to do this, get 200 participants. And I would say here that as you might be gathering, this was a very typical kind of pharma trial where they have a lot of sites and each site doesn't have a lot of participants, right? So we couldn't we couldn't contract with like 50 sites. We just didn't have the money for that. So we had to kind of balance out. We were trying to find the big sites. So the goal was to get 12 sites, 200 participants, do some querying, and get this, data evaluation back. So when we were talking to sites, we were like, okay, you have to have a data warehouse based on your EHR data kind of available. You need to have the staff available and the know-how to organize that data into a common data model format. And what that really requires is kind of an integrated clinical, operational, and technical team. Now, coming from Duke, I think we saw how that might be possible because, of course, we're at Duke. But there were a lot of sites that just couldn't do this work. Like the research apparatus at these sites really had to be pretty well developed. And not all sites, especially, small clinical research sites, had what was needed to do this work, unfortunately. So again, we planned for 12 sites and 200 participants. We ended up getting 8 sites and 147 participants, and uh, finally got data because, again, some of those contracts kind of just didn't work out because this is difficult work. Um, Data from 69 participants from 7 sites. So it turns out, by the way, that the actual flow of data that we wanted to do was really nothing like the PCORNet data mart strategy. We had big plans, and those plans didn't work out. There was one PCORNet site in the study, and for them, this worked like a dream, right? We sent them a program, they sent us the results back. It was the easiest thing uh, in this entire trial. But for the other sites, um, or for their EHR vendor. Somebody had a cloud EHR vendor, so we ended up working with them. What they ended up doing was sending data extracts to Duke for processing, and we kind of put it into a common data model format at Duke and then queried it. It just turns out that this work is, again, not surprising, but it's very hard, and there's no standard extract from from Epic or anything at this point. So there was no like button people could hit to send us their data. It ended up being very difficult. Whatever. So we did end up comparing a number of things between the trial database and the EHR data and claims data. It was in demographics. We looked at medical history. We compared what medications people were on, a few laboratory results, and then events. But again, we only had, under 200 patients for this whole thing. Um, just to give you a sense about kind of what we found, and don't stress too much about all the numbers on here. I know when I typically show this slide, people really want to dig in and worry about specific numbers. But I think what's kind of more important is to look at in some way, the trends, right? The results were, slightly, I guess would say, it's hard to totally summarize this table, but in general, it shouldn't say real world data. It should say claims data. Oh, in general, like sensitivity was lowish, right, for many things, but specificity was often high. So if something showed up in terms of a medical history in EHR data or in claims data, again, this is generally true. It was true, right? But you didn't always see it, especially when you're comparing it to asking a patient or getting a full kind of history on somebody from a full medical record. What we're doing here was just looking back 1 year, right? Another thing you can kind of see is that in some way, generally, if you squint, Medicare data had better sensitivity than EHR data. And for medications, same sort of story, which is like Medicare data was actually pretty highly sensitive and pretty highly specific. EHR data was less sensitive, but very specific. I think, again, one of the reasons for EHR data is that if they didn't get prescribed that med in the research site, you just won't see it, right? So that's a reason for low sensitivity there. Demographics, of course, always matched, no big deal. Lab results from the EHR data agreed when they were present, but they were often missing. And it was hard to say anything about events because, again, with like 200 patients and rare events, we just had very small numbers in order to say anything. But again, we kind of saw maybe the claims data did a little better on that because again, it's kind of a comprehensive um, thing there. So I want to talk here about lessons we learned kind of the hard way. One of them I alluded to already, which is that standalone clinical research sites kind of have very little extractable EHR data about patients. And in trials like this, there were a number of standalone clinical research sites um, that just it couldn't help us very much. Um, some EHR data is much more readily available than other EHR data. Anything that's structured, codes, dates, very easy to get. Um, Lab results and medications were either not extractable, although they often were, but even when they were, they weren't always mapped to a useful terminology, right? So everybody's got their internal codes for labs and internal codes for meds, but we need to get them to something common, and that's not always straightforward. If you wanted to say, hey, is your data, what's the data quality of your EHR data ahead of time? That requires you to look at an entire site's EHR data, right? Not just the people you're dealing with uh, who are enrolled in this particular study, but like the whole thing. And that's just not going to happen unless they're participating in something like PCORNet. So we didn't really have the sense about, you know, was the data any good? What data was there, wasn't there? The only site we knew about that was the one that was participating in PCORNet. And then, of course, pre-processing EHR data into a data mart is very difficult for trial sites. We talked to many, many trial sites from this study, and a lot of sites basically knew they couldn't perform the work, so they just didn't even join on. There were sites who promised to do the work but did not deliver. And again, the study site participating in PCORNet did wonderfully because again, they'd already done that work. So that was one thing where I would say real world data was an add-on. Okay. Now we move just briefly to the adaptable pragmatic clinical trial. So this was a trial where we wanted to study 2 doses of aspirin, full dose and a quarter dose for patients with cardiovascular disease to assess kind of secondary events here. It was going to be 15,000 patients. We were going to use, or we did use PCORNet to conduct the study and disseminate the results and get all the data. This was a PCORNet demonstration project, and the goal was to be as pragmatic as possible. So the original intent was really to rely on EHR data for almost every single aspect of the trial. So that meant recruitment, that meant baseline data, that meant follow-up data. It kind of meant everything. It was, all things considered, a relatively cheap trial for 15,000 patients. Now, I've just talked about how EHR data has holes that we all know about, right? If somebody goes down the street, if I work at Duke, right, and if somebody goes down the street to UNC and gets hospitalized, we won't know about it if they're a Duke patient, right? So the protocol for adaptable did acknowledge the existence of these out-of-network events and the need maybe for claims data and patient self-report in order to have complete events ascertainment. But it was like one bullet point. But it was the bullet point that I think ended up giving us the most heartburn in this study here. And I'll demonstrate that in a little bit. So here, this is what I was saying earlier. Real world data was meant to support participant identification. Again, since PCORNet has all the EHR data already transformed into a common data model, we could theoretically at least apply the inclusion-exclusion criteria to the PCORNet data and say, hey, here are your participants who would seem to be eligible for the trial. Go send them a note, right? Um, Once people enrolled, we would get their characteristics by PCORNet, all-cause mortality, um, hospitalization for MI or stroke were the main outpoints, and then coronary revasc was a secondary one. And then the safety endpoint was hospitalization for major bleeding. All of that, maybe not mortality. I was going to say, I forget how exactly we did that, but all the other ones were really supposed to come from claims data only. So we all know about participant identification in trials. We made a computable phenotype, right? to identify patients eligible for adaptable. Um, we implemented this at most sites, and it it worked-ish, I would suppose. I'll tell you in a second why it was difficult. But what's funny is because we said, "Hey, apply this to your PCORNet data," um, and then ask certain people to join, and they go to a website and then kind of self-enroll and other thing. It made the consort data diagram that we often do for trials almost impossible, because it was hard to know where to start. I think they eventually started at people who made it to the website. Um, but in terms of how many people were approached, we had less good information about that. So computable phenotypes only work if the definitions are easily implementable in data like PCORNet. So these were the inclusion-exclusion criteria as written in the protocol, and they were very traditional. Um, you just look at this list and think to yourself, what might be readily available in structured EHR data? Um, and it's not everything, right? So the things not in red were things that we actually were able to implement in PCORNet. Just of course, like access to the internet. That's not something we can really know about in PCORNet. Allergies actually super difficult to ascertain in coded data. Um, Test results like this were not readily queryable. So it's funny, this was written as a traditional thing, even though they knew they wanted to implement it in EHR data, but they didn't kind of merge that thinking there. So there, I think some of these things we definitely had to ask people when they came to the website, because it was, otherwise impossible to apply that. Um, Similarly, the endpoint was very different from kind of the model outcomes in most traditional clinical trials. On the right here is the typical adjudication criteria um, for MI, right? And on the left is what we used, which was an inpatient encounter with a diagnosis of 410 EXA and 410 X1. We did, of course, move these into ICD-10 codes when that came about, but a very different set of criteria. Because again, if you want to be pragmatic, it's not only the data that's pragmatic, it's also the definitions that have to be pragmatic. So here was the pain a little bit. I know this is a little bit blurry, but um, endpoint ascertainment basically followed two paths. If we saw something in EHR data, we believed it. We actually did end up getting Medicare claims data for people, and if we saw an event in that, we just accepted it. We did end up, I think, getting some data and enrolling folks from Blue Cross Blue Shield um, up in Pennsylvania. And again, so we got their data, and if we saw an event in there, we believed it. But we also asked patients on the patient portal about their hospitalizations. And um, if what they reported coincided with something we knew about, we just accepted it. But if not, we we kind of had to chase it down. That's what we set ourselves up for. And that's chasing things down. You don't really need to look at the details here. It's just that it was very, very difficult because it required us going to these out-of-network sites. It required us getting people to sign, disclosure agreements and things. And it ended up being very difficult, and we ended up not getting a lot of information about these out-of-network events. Um, so that ended up being, I think, a real time suck, and really, really difficult. In the end points did end up coming from a variety of places. So for the most part, EHR and claims uh, made made up like 90+%. Well, let's say 90% of all the events that we actually included in the final analysis. Um, there were, 7, 10, I think 10-ish% that did come from the patient reported process, which is good, but it's possible that's just higher. It's just that we just weren't able to track most of those things down. So there's basically a lot of data to keep track of here. Um, so what did we learn from adaptable? Well, you really need to change not only kind of the data sources that you're using, but also the trial itself, the operational and design aspects of the trial. So you really have to consider the real world when planning the trial. Is it possible that maybe you target populations with more complete data, right? Maybe you recruit from sites affiliated with large health systems and just work with those health systems. Again, I'm not saying any of this is easy. I'm just saying, like, if you really want to use real world data as your sole thing, there are some things maybe you could do, right? Um, Perform the trial within a specific insurance population, whether that's a private insurer or whether that's public insurance like Medicare fee for service. You definitely have to define the history and event concepts to be more real world data friendly. Um, Keeping in mind that things like prevalent disease, if you're looking at history, is much easier to identify than historical clinical events, which may have happened years ago prior to the data that you've got. And you really need to understand, which again, if you've not worked with these data, which a lot of maybe the clinicians at Duke hadn't, um, you have to think about what's available in structured data, right? Or easily obtainable for research, and write your concepts for history and events that way. Um, we ended up spending a lot of time, with kind of project management folks, making sure we had the right data governance processes in place. Like, data governance is a very difficult, constantly moving thing. Um, they're hard to navigate, and so when dealing with other sites and their data, that's going to take longer than anyone thinks it's going to. What we strive to do is, whenever we do a study with real world data, is try and um, commit to trying things that are new and reporting what works and what doesn't. We still need to all figure out, because there's more to learn, and there's more to try here. Um, some of the things we've been thinking about and hopefully working on soon are like bulk fire, which enables data transfer for more patients instead of the single kind of query that happens now with kind of general fire interfaces. And blue button direct authorization, where patients basically say, yeah, 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 you can go look at my, uh, you can go get my claims data. I authorize you to do that without you having to, currently we send social security numbers to Medicare. It's kind of insane. Uh, but this would be much more direct. So there are ways maybe we could get access to these data a little more cleanly. So we took some of those learnings from Adaptable, um, and tried to put them in place in Preventable. So Preventable is an NIA trial that Duke is working on with Wake Forest. It is evaluating, this is, again, a very different population, age 75 plus, without CVD, dementia, or disability, hoping to get 20,000 patients randomized to statin or placebo and then followed for many years, so that we could see if somebody survived without dementia or persisting disability. The secondary endpoint was a CV composite, the main one. There's another one of MCI or dementia there. So real world data was going to be used in this trial. That was the plan all along. We're going to use, again, EHR data, this time not only from PCORNet, but also from the VA and from independent sites. The plan is to get Medicare data, which we've just started doing, and to get National Death Index data. So real world data is a part of this, but it won't support everything, right? So they still tried to use it for participant identification. They used it for some medical history, but not all medical history. One of the things I think we learned is that, like, if you need a certain medical history concept because you want to do subgroup analysis or something, you need to collect it in the baseline CRF. You can't necessarily hope that it shows up correctly in the medical history form or in the real world data you're collecting. So for things that weren't essential, we kind of just said we'll get that from the data. That would enable us to keep the CRF relatively lean, which is nice. For the primary endpoint, again, which is dementia and persistent disability, if we see codes in the data that look like they're related, we see codes for falls or something, or codes for dementia, but we don't necessarily know about it yet, that'll trigger essentially like a follow-up process. So it wasn't being used to define those things, but it was being used to trigger that. Where real world data really were relied on was for secondary endpoint ascertainment. Um, Cardiovascular mortality, hospitalization for MI, heart failure, or stroke, stroke TIA. That was uh, only going to be real world data. And it was only going to be available data. There was going to be no chasing down out of network things. This was an endpoint, of course, that's not powered anyway. And they just made the decision up front. We know it might not be 100% complete, but we're hoping that that difference is basically non-differential between our two groups, and we're just going to run with that. So that enabled all the secondary endpoint ascertainment um, to be just a data process instead of having to have money spent on follow-up of actual patients and dealing with sites on that. So um, that was a very pragmatic choice, so to speak. Uh, so that trial, by the way, is still in progress, and we'll see how it's going. I think we've just recruited about 10,000 patients, but um, yeah, the original funding period for this, I think, ends next year, and we're still waiting to see what happens next. I think everything, who knows at this point. Um, And of course, the work that Elizabeth referred to initially here is that we're working um, with Hopkins on the CMS linkage to the PCORI reliance trial. So one of the new things here is that not only are we using fee-for-service claims, we're also using some Medicare Advantage encounter data, which is the Medicare HMO data. Um, We're comparing trial-based ascertainment of endpoints primarily to the Medicare-based ascertainment of endpoints. That's happening literally right now. Um, and again, this activity. This was a quote from, I think, one of the original proposals for this linkage. It really, this was to support the FDA's assessment of the use of real world evidence. They're still interested in it. We're still talking with them, and so we're still hoping to learn lots of interesting things from this work. There was meant to be a methods component that Harvard was leading, um, excuse me, which would have studied distributed regression methods with vertically partitioned data, meaning what if outcomes are over here, but the baseline data is over here? Um, how would that work? And Darren Toe had a whole thing about that, but the trial duration made this work unfeasible, so we had to jettison that objective, unfortunately. But yeah, interested to see how this goes. Um, I think that one of the things that everybody learns when you do a comparison of kind of trial collected data with real world data is that sure, it's true that real world data is not perfect, but it's also probably a little true that the trial data is not perfect. And we normally have to assume, I mean, I say this because when you try and set up a gold standard for like a 2 by 2 table, at some point you ask the question about, well, which is the gold standard? Like, and it's actually not a straightforward question. You want to think it's the trial collected data, um, but that's not necessarily true. And we just don't often know that. We often don't have anything to compare trial data to, if that makes sense. So we have to, and I think it's reasonable to assume it's the gold standard data, but it, yeah, there might be some funny, uncomfortable questions when we realize that, oh, maybe there are things we're missing in the trial data. This has been true for everything we've worked on so far. So it's kind of an interesting aspect to it. But that's what I had for you. I'm happy to answer questions. Um, and thanks so much.
Great, Brad. Thank you very much. So yeah, we'll open the floor. If anyone has questions, you can either raise your hand or put the question in the chat. I guess I'll take a stab
Sure.
since no immediate response. I guess how do can you talk a little bit about how, the restrictions you talked about, where you could do this and what does that mean for generalizability? Because in one way, you get more generalizability by trying to reach many more people, but in another way, if you're restricted to certain sorts of facilities that have certain data systems, you have a cramp on generalizability. And any thoughts as you sort of work with some of that?
No, I mean, that's a really great point, and I think a difficult aspect of trying to tap into real world data in the US, which is that, um, y- yeah, that would put a cramp on things, and that would be difficult. I would say so many trials already recruit a somewhat unrepresentative population anyway that might be less of a deal than we think it is. This is one of the things where, whenever we talk about this work at conferences, somebody from Europe comes up and says, "Yeah, we just don't have that problem," and I'm like, "Yeah, well, that's the dream, right?" Um, so they're much more poised to take advantage of national databases, and not have to worry about where they're recruiting from or looking at specific different populations. So, yeah, until we get there, it's just not a reality over here, I don't think, unfortunately.
Yeah, and I mean, you could argue that in some ways, we already restrict to those people
Mhm.
in general for trials, but it is an interesting question. So Doug, did you have a question?
Yeah, so a colleague of mine did a study of an eye infection called acanthamoeba keratitis. And he looked at EHR data and he looked at people who were coded for it. And then he went and reviewed all the charts. And what he discovered was that only 10% had acanthamoeba keratitis. The other 90% were coded that way because they were being evaluated for it, but they didn't actually have it.
Right.
Now, obviously, that's an extreme example, but patients get admitted to the hospital for evaluation for MI and turn out not to have an MI. How did you handle the fact that sort of verify the data for the events, or did you? I mean, it might be able to do it from taking claims data and looking at the EHR at the end as well. But what did you do as regards that?
Yeah, that's a great question. As part of Adaptable, there was just a small study where it was a validation study where we got the actual kind of medical records for a handful of events at a number of different sites, and they generally showed very, very well. Now, I think, meaning like if it was said it was for MI, it was for an MI. If it said it was for a stroke, it was for a stroke. And I think what helps us with respect to that is that, especially with claims data, and especially in the inpatient setting, right? Primary diagnoses are supposed to reflect the reason at discharge, essentially, meaning once we know why they're here, um, that somebody was admitted to the hospital. So that differs, of course, right, from the admitting diagnosis, which is like, why do we think you're here? Um, so we don't really deal with the admitting diagnosis. Um, we really rely on that primary diagnosis, which is again supposed to reflect knowledge. And so that really helps, at least in claims data, at least in the inpatient setting. But for things that are in the outpatient, I think your eye diagnosis example is a really, really good one. Um, because you're right, you can code somebody for kind of rule outs. It doesn't have to be the reason for the visit or anything. And so anytime, right, you're dealing with outpatient diagnoses and if you wanted to use that in a trial, yeah, you would probably have to either confirm it in some way, or sometimes what we do just as a minimal thing, if we only have access to data, right, is just say, well, I need to see that thing twice, maybe, or I need to see it diagnosed by a certain type of provider or something. So there's ways you can hopefully make that more specific. Um, but yeah, no, there's definitely, I think, risks to only relying on real world data, for sure. If you really, really have to know stuff, there's got to be some way to um, that you could confirm it. If Yeah, which is again why I think what's happening in Preventable is interesting, which is they really spent all their money on the primary endpoint, which they're going to talk to people about and assess patients directly and look at charts directly. Because that's the one that matters. So the one that's less important but still kind of interesting is the one that they're just going to rely on real world data for.
Any questions? Cheryl.
Yeah, hi, Dr. Hammill. I'm interested in learning whether it is possible that like certain variables within certain types of real-world data are more reliable than the other types of variables. For example, the medication informations in claims data, would you say that that would be kind of reliable kind of data source if we would like to utilize some part of the real-world data?
Yeah, I think that's a great point. I think one of the big differences we see in medications from different real world data or different kind of quality we see with respect to medications in EHR versus claims is, yeah, medication information is really good in claims because it reflects dispensing, right? It reflects somebody actually picked this up, it got paid for. Again, to the extent that people do over the counter or generics paid by cash, which is has been shown to be less of a thing than you think it might be. Um, Claims data is great. Part D data is, I think, terrific for understanding what people are taking and when they're taking it and how much they've gotten, so to speak. EHR data, some people have dispensing information that they can give us, but most people rely, I mean, the data source relies on prescriptions. And prescriptions are very hard to deal with um, for two reasons. One, as we all know, prescriptions don't equal dispensing, right? So a lot of, if people don't pick something up, then they didn't get it. But another thing is that for chronic meds, you might have one prescription per year that covers refills for the entire year. So whereas in claims data, we can just look and say, hey, well, were you on a med like within 30 days of trial randomization or something? Um, in EHR data, you kind of have to look back a year or more and say, did they have a prescription for, again, if it's a chronic thing, and for something like statin, the statin trial and preventable, we had to look back, a year to say, did you have a prescription for statin available? Um, and then we had to assume that you were still on it, right? So there's a lot more assumptions with regard to medication data in EHR. It's a little more iffy as far as I'm concerned. So procedure data is good. I mean, also, like, again, diagnosis data is what it is. Procedure data is great too, because uh, there's no like rule out for procedures, so to speak. If you got the procedure, it's going to be coded and it's going to be paid for. And so when we have these coronary revascularization endpoints, they're great, honestly, because that stuff always shows up.
Great, thank you so much.
Yeah.
Can you talk a little bit about the impact of lag? Like, so you're mentioning, for example, with the medication data, but also like the National Death Index is an even longer lag, and sort of as we're picking our outcomes, that seems to be another factor to
Yeah, no,
or
I think
take into
that's
account.
it's a huge factor. I would say one thing that helps with NDI is the early release, where they do release the early release pretty quickly, where like 90% of when 90% of the deaths have been kind of reported and validated or whatever. Um, so that's not so bad. Um, but yeah, Medicare data, again, they have quarterly releases of data, but even that's 5 months, 6 months old by the time you get it. Um, but that's the best from Medicare. And if you want Medicare Advantage, it's, years back. So it depends on how quickly your trial needs to go. So for a trial like Preventable, where, I mean, we've been in this 6 years and I think it's going to be 3 or 4 more, you know what? Having a year lag is not that big a deal, right? In fact, even for Reliance, the fact that it went on longer in some way helped us. Like, because it's like, okay, well, we can ask for certain types of data that maybe we wouldn't have initially, because we know that it's accrued and we know it's available for this. So yeah, I think real world data it can become difficult if you have a very short timeline, meaning claims might be off the table. Now, data might be on the table because if you're working with a site, I mean, those data are basically live, right? Um, so yeah, that might be that. So one of the interesting things about the blue button technology, because CMS actually has like an API for this, and we've made a little tool for it and we've tested it and it kind of works, but the hardest part of that. And again, Blue Button is where we say to patients, hey, can you share your data with us? Because we'd love to use your data for follow-up in a trial or in a study of some sort. And they go to the website and click the button, and that click is associated with us, and it means we get a feed of their data. The hardest part of that, just for what it's worth, is the actual authorization process, because no one knows their password, right? And so you have to reset passwords, and it's a whole big thing. But once the feed is established, it's actually really great, because that is dealing with kind of the live claims database at CMS. So within a few weeks, you know about things that happen in Medicare instead of having to wait 5 months or multiple years. So that's why I really think there's possibility there. It's just it's hard to implement, and I wish it
Right.
weren't so hard to implement.
Other questions? Well, no, I want to thank you again, Brad. I mean, I think this is a lot of thought and a very exciting area, and definitely makes us do, as you said at the beginning, a different type of planning as you're thinking about outcomes. How much time do you want to get for data to accumulate and everything else? So definitely, great insight there. So thank you again.
Great. Thanks so much for having me.